Welcome to the University of Washington Tracheotomy Care Training video, module on accidental decannulation. By the end of this video, we anticipate you will be able to list the emergency equipment needed for patients with a tracheotomy tube, describe the steps to assess accidental decannulation and ensure adequate oxygenation and ventilation during accidental decannulation, and describe methods for recannulation. Decannulation refers to the situation where the trach tube comes out of the tracheotomy tract and may no longer be functioning properly. If a patient depends on their trach as their airway, this can represent a medical emergency since the patient may not be able to breathe. In addition, the trach tube can also be partially out of the airway such that it actually blocks an airway that might otherwise be open. Accidental decannulation may result in more serious complications for your patient. Many sentinel events resulting in patient deaths have been reported when a tracheotomy tube has become inadvertently decannulated from the airway. Although accidental tracheotomy tube decannulation can occur in many different types of situations, there are several risk factors to help identify patients who might be at risk for inadvertent decannulation. First, a recent tracheotomy within the last 7 days, increased airway secretions, vigorous coughing, mental status changes, lack of restraints, unsupervised confused patients, change of shift, and loose tracheotomy ties. Although we cannot completely eliminate the risk for accidental decannulation, if we are aware of the risk factors and take necessary precautionary steps, we can reduce accidental decannulations. And if they do happen, we will be prepared to respond appropriately to this emergency. First, monitor the tracheotomy tube during your rounding. Note if your emergency trach kit or spare tracheotomy tube is at the bedside. Ensure that the following equipment is at the patient's bedside: a spare trach tube of matching size and type. Consider having a trach tube that is one size smaller available for an emergency if needed. Lubricant, self-inflating or flow-inflating resuscitator. When you are concerned about a decannulation, you must first inspect the tracheotomy tube in the stoma. The flange should be sitting right up against the skin. If the tracheotomy tube flange is away from the skin, and you can visualize the cuff or the end of the tracheotomy tube, then the tube is most likely not in the trachea anymore. If you suspect that the tracheotomy tube is no longer in the trachea, you should call for help. Assess the patient to determine if they are moving air through their native upper airway. First, assess patient color and work of breathing, followed by oxygen saturation. If the patient is not adequately breathing through their native airway, it will be necessary to assist them. This should be accomplished by the two following methods. Hold a sterile 4x4 gauze or other object over the stoma while you ventilate over the nose and mouth with a resuscitator mask and bag. It may be necessary to have an assistant available, as this can be difficult to coordinate by oneself. If the native airway is not appropriate for bag mask ventilation, such as the case with a patient who has suffered severe facial trauma, you may place the mask over the stoma site and attempt to ventilate. If the tracheotomy tube is less than 7 days old, you should wait for the providers who placed the tube to reinsert the tracheotomy tube. This is because the tract has not fully formed and the risk of placing the trach in a false passage in the soft tissue is very high. Once oxygenation and ventilation have been assured, you should prepare to replace the tracheotomy tube. You should replace the tracheotomy tube with the spare trach from your emergency supply. First, check the integrity of the cuff by inflating the cuff and checking for leaks. You will then deflate the cuff and position the patient for reinsertion. The best position to reinsert is for the patient to be flat with their neck hyperextended. You may place a blanket or pillow under their shoulders. Do not hyperextend the neck if the patient has a confirmed or suspected cervical spine injury. Insert the obturator into the tube and apply lubrication. Apply firm pressure to the obturator or introducer as you insert the tube and slide the tracheotomy tube into the trachea. Stay sutures fastened to the trachea may be in place. If they are, hold them open to aid in reinsertion of the tracheotomy tube. Once the tracheotomy tube is in place, quickly remove the obturator and insert the inner cannula if the tracheotomy tube has one. Assess for proper placement by ensuring there is good airflow through the trach tube and by listening for bilateral breath sounds. Other methods to check for proper placement would be end-tidal CO2 or a colorimetric CO2 detector. In this module, we provided an overview about the importance of identifying patients at risk for accidental decannulation, how to assess patients for suspected decannulation, and how to reinsert a tracheotomy tube.